You're listening to the Physio Matters podcast this month in association with rehabilitation.com, and this is session 87. Hello everybody and welcome back to the Physio Matters podcast. I'm sure you are wondering that does not sound like Jack Chew, and you would be correct. It's Jack March here from the team, and I have been given the glorious job of introducing and recording this session on one of my very strong interests, osteoarthritis. Before we get into the show, I want to say thank you to this month's sponsor, Rehab My Patient. I've been using their online consultation software recently, and it really is absolutely excellent and sticks up to the high bar that they set with their exercise prescription software as well. Today's podcast is all about osteoarthritis, and we know that exercise is super important for the management of osteoarthritis. And alongside that, what do we need more than anything else but a great suite of exercises and exercise prescription software that is going to be able to help us deliver that in the best manner possible and the easiest time-saving manner as well. So do head to rehabmypatient.com/physio matters, and you can sign up there and you get 3 months free access, and it's just purely brilliant. So make sure you head there. That's rehabmypatient.com/physio matters for that deal. In other exciting news, we've been over the last few months working with a US tech company, Active to make their products more user-friendly to the MSK industry. This has culminated in the launch this week of the Active Force 2, which is a digital dynamometer and goniometer, fits in your pocket, and it speaks to its own native app to record strength measurements and range of motion, which is pretty awesome. It can be easily adapted to every body part, and exclusively through us you can get the device for just £300 and also get the app subscription completely for free, which is brilliant. The only place that you can get this offer is physio-matters.com/AF2. So that's A for Alpha, F for Foxtrot, and the number 2. This makes it a third of the price of its nearest competitor, and then you add the free app subscription on top, and it's just a mad deal. So you want to head to that landing page as soon as you can and snatch one of those up. We are going to potentially be a little bit limited on supply. So head over to the link physio-matters.com/AF2 and start adding more objective measures to your assessments immediately. So on with the show, and this month I am joined by Professor Tonia Vincent, and she is a consultant rheumatologist. She directs the Centre for OA Pathogenesis funded by Versus Arthritis, and her research interests include pathways that drive mechanosensitive responses in cartilage, which is as complex to understand as it is to say, the role of pericellular matrix in determining some of those responses, and how they modulate osteoarthritis in vivo. What she doesn't know about osteoarthritis probably isn't worth knowing. We get into so much depth about the pathogenesis of osteoarthritis, what that means for physiotherapists, what that means for exercise, what that means for our rehab, or what research into osteoarthritis will come up with in the near future. It's absolutely fascinating. I suspect this will blow your mind as it did with me, and I also suspect there's going to be a lot of feedback, a lot of discussion, and please do get involved in that with us on social media or by email. So just find us anywhere on social media by typing Physio Matters. We usually come up. You can always email us as well, info@physio-matters.com, and we will continue those discussions. So without any further interruptions, I'm going to let you get into the show and enjoy this podcast with Professor Tonia Vincent. And today. So welcome to the show, Tonia, and would you mind just introducing yourself to the listeners with a bit about what your job role is and what you're up to at the moment?
Yeah, thank you. So yes, I'm Tonia Vincent. I'm an academic rheumatologist. So I trained in rheumatology in London and then very quickly went into research. So I actually spent 80% of my time in research and only 20% doing sort of face-to-face clinical work, slightly more at the moment because of COVID. And I am pretty much laboratory based. So a lot of what I do is understanding basic pathophysiological processes that happen in osteoarthritis. Because about 20 years ago, when I started doing my PhD, it became apparent that this was a disease that we just really had so little understanding of at the basic molecular level. And there was an awful lot of assumption in the literature. And there was an awful lot of, textbooks that said, of course, this is an inevitable disease of aging. This is wearing down of the joint, just like the rubber tire on a car. And it was emerging at that stage that really was far from the truth, that the cartilage was a live tissue, that it responded to these mechanical factors, and that's what was triggering the degradation of the matrix, the breakdown of the tissues in the joint, and so forth. So I've spent 20 years now looking at those, going really back to basics and trying to understand what those responses are. And in doing so, along with lots of other people worldwide, we're really building up quite a comprehensive molecular picture of what osteoarthritis is and its complexities, but its targeting strategy. So it's a very, very exciting time for OA.
Yeah, it sounds it. And I think one of the things that might surprise a few of our listeners would be that a rheumatologist is involved in osteoarthritis. As you said, I think it's still relatively pervasive, the idea that the joints wear out like a car tire, and it is this sort of use over time that means that the cartilage thins or whatever it is. So would you just comment on how you got into osteoarthritis specifically as a rheumatologist and how that sort of impacts on your clinic as well, clinic work these days?
Yeah, I mean, that's a really, really important question. Of course, when you're setting out as a would-be academic rheumatologist, which for me was at the end of the 1990s, everybody said to me, you've got to find yourself a niche, you've got to find yourself something that sets you apart from everyone else. And I can tell you, everyone else was working in inflammatory arthritis or in some of the other inflammatory arthritides, and working on anti-TNF and anti-cytokine therapies and so forth. And I'd done immunology as an intercalated BSc when I was an undergraduate at UCL. And as much as I'd enjoyed immunology, I just found it really dull. And so I was really attracted by matrix. I was really attracted by the solid tissues. I liked bone at the time. I was very interested in osteoporosis. And so when I was looking to do a PhD, I sort of went around different units, and I spent a lot of time at the Kennedy Institute because I was at Charing Cross Hospital at the time. And I went to meet various of the PIs in the Kennedy, trying to find something that would really sort of interest me. And I chatted to Jeremy Sacklet-Vala, who subsequently became my supervisor and a great mentor. And he had worked on lots of different things, including immune cells, but actually one of his great loves was looking at articular cartilage and understanding how interleukin-1 causes this very profound breakdown of the articular cartilage in vitro. And one of the experiments that they were doing in the lab at the time, and this was completely fortuitous, it was an accident, was they were taking bits of cartilage and putting interleukin-1 on them and trying to look at some of the signaling pathways inside the tissue. And what they found by accident was that when they cut the cartilage to put it into a test tube to then put the R1 onto it, they found that all the signaling pathways had already become activated. So all the things that IL-1 would normally do on a monocyte, the chondrocyte was already doing. And so to cut a very long story short, we went backwards and said, well, what is mediating this response? Is that really what the chondrocyte is doing in the body, in the tissue, or is it some response to this cutting? And we found that it was actually the mechanical injury of the cartilage that lights up every single signaling pathway. And for years before this, everyone had always assumed that the chondrocyte was this incredibly quiescent cell that didn't do very much, just sat in the tissue, churning out a little bit of matrix. And suddenly, here was a stimulus, simple mechanical injury that lit up every single pathway, turned on all the genes that TNF or IL-1 or any of these inflammatory things would have turned on. And so I remember Jerry saying to me, just prior to me starting, saying, well, you could work on a monocyte and look at the P38 pathway, or you could follow up this kind of interesting observation that cartilage responds to injury in this very, very striking way. And I said, that's the one for me. And so that's what I've been doing basically for 20 years. I've been building on this observation, which is that chondrocytes are exquisitely mechanosensitive, and they turn on pretty much every pathway we've looked at, they turn on as soon as they're injured. And that has been a fascinating journey. And that takes us on to, what these pathways are doing, what the molecules are that are mediating this, and so forth. So that's how I got into osteoarthritis. And I remember also going to I think when I was a Wellcome Trust intermediate fellow, and I went to one of the Wellcome Trust meetings, and it was when Mark Walport was head of the Wellcome Trust. And as you may remember, Mark Walport is also a rheumatologist previously, and I'd worked with him as when he was a consultant at the Hammersmith Hospital. And he had said to me, what is this going to tell you, Tonia? You're doing these sort of injury experiments in vitro, but how is this ever going to relate to the patient? And I don't remember my exact answer at the time, but I think I said something to him, well, we know that mechanical injury is the most important etiological factor in driving osteoarthritis. So it's highly likely that the pathways that we discover are going to have some clinical relevance to the patient. And I think 20 years later, and Mark, if you're watching, hello, 20 years later, I think we can absolutely say that it has taught us a huge amount. And now we're just beginning to think about how we're going to target these pathways for clinical benefit. It takes a long time, but there was an awful lot to discover for this disease.
Yeah, it's certainly listening to you there, it certainly strikes me as this very, very big change from what I suppose in my head is pretty much was assumed the simplest musculoskeletal problem you could get. Overuse your knee and it'll degenerate, to an incredibly complicated process. And especially there's a very pervasive idea within certainly physiotherapy that osteoarthritis is a very systemic disorder. It has a lot of factors affecting it, that actually, things like body weight, smoking, activity levels are all in a very complex interplay. Would you mind just, before we go back to the injury mechanisms you were just talking about, how much do you think that those are playing a role in the development of osteoarthritis, or are they sort of supplementing a process that's already occurring, if that makes sense as a distinction?
I think that's a really good question, and we don't fully know the answer to that. So if you take one of the pathways, the first pathway that we discovered was a growth factor that is, the cartilage is such a clever tissue. We've, for years and years, we just thought it was this packing material. So the cells, as you probably know, the chondrocytes within cartilage, they're a very, very small number of them. So by volume of the tissue, they only make up about 5% of the total tissue volume. So 90 to 95% of the cartilage is just extracellular matrix. It's collagens and proteoglycans and things like that. And that's why people have always thought of this being a really dull tissue. It doesn't do anything because it's all packing material with a few cells. But it turns out that that packing material is very, very much more sophisticated than we gave it credit for. There are two principal bits of this packing material: the bulk matrix, which has got all the collagen, and the aggrecan, which is the main proteoglycan. So it's the main sugar chains within the extracellular matrix. And then around every single cell, every chondrocyte within the tissue, there is this little halo of matrix called the pericellular matrix. And within this region are a whole host of growth factors. And they're all sitting there poised, ready to receive a mechanical stimulus. And I don't think they are released when we go walking. I don't think if you're a runner, when you go running, they get released. But I think they get released when you go above your threshold, whatever the threshold is that's been set for that patient. And these are the good guys. They're all growth factors. These are repair response factors. These are possibly factors that enhance the thickness of cartilage. If you exercise, your cartilage will thicken. If you, God forbid, go into ITU for a couple of weeks, your cartilage will thin. It's just like bone and muscle. It atrophies when you don't use it, as I'm sure you guys know more than anyone. And so I think these factors, these are the good guys, and we probably don't activate them except when we've gone above that sort of injury threshold, whatever that is. Now, conversely, there's another whole set of pathways that activate inflammation within the tissue. And we believe that it's the type of mechanical stress on the tissue that is activating these pathways that's quite distinct from activating the good guys. And I'm sort of jumping ahead of myself here, but I think I'll get back to the sort of more clinically relevant part of your question. What we think we've discovered over the years is that compressive load, so if you think about uniaxial load on the joint, is actually really good for cartilage. So that's sort of, weight-bearing activity. That's the same for bone and for muscle. You get your patients doing sort of stomping exercises, then they'll actually increase the health of these tissues. But if you slip around on the joint surface because you've got increased shear stress, because you've got instability, you've got weak muscles, you've got a meniscal injury, any of those things, you've lost some of your gait reflexes as you get older and so forth, then you increase that shear stress over the surface. And shear stress is what drives those inflammatory signaling pathways, which are the ones that induce the enzymes. They're the ones that induce some pain molecules, and they're the ones that really cause this degradation of the matrix. So we think that mechanics is really important, but there are really distinct signals that are coming through the joint that determine whether you activate these good pathways or these degradative pathways. And that might be why the literature is so confusing, that, doing more exercise can be on the one hand associated with thicker, healthier cartilage, but on the other hand may predispose you to getting premature osteoarthritis. So, what's quite interesting a lot of what I'm basing this on, it comes from preclinical models, comes from models in mice rather than in humans. But I think it aligns really well with the sorts of principles that physiotherapists have, which is that you want to stabilize the joint, you need to build quadriceps muscles, support the joint when you use it so that it's not sliding around on its surfaces, and it's just getting good compressive load. And obviously you have to bend your joint, so you've got some of this, but you're not also shearing the surfaces excessively. I've probably gone off the original question. Apologies for that.
No, fascinating. I do want to come back to these shear forces, if that's okay. But I just want to press on to the point about you. So you said about obviously the inflammation being potentially caused by those shear forces. So we then sort of suggesting that those other things that I mentioned that might increase your systemic inflammation, like high BMI, smoking, poor diet, those sorts of things. Is that a case that it aggravates those pathways, or is it a case that those pathways are slightly elevated because of those factors? So, or is that we can't make that distinction?
I think it's really difficult to make that distinction, but the way I've always argued this is that mechanical stress is the key driver of osteoarthritis. If you immobilize your joint, it doesn't matter how obese you are, it doesn't matter how much you smoke, it doesn't matter what you eat, you won't get osteoarthritis if you're paralyzed. So you have to have that mechanical load going through the joint. And then I suspect, but I don't know this for certain, that those systemic factors then contribute to the tone. So it might just somehow reduce the threshold for that inflammatory activation within the tissue. That would be one hypothesis. There are other hypotheses which I think are emerging, which are also very interesting. So, for instance, we know that a lot of the systemic factors that you refer to, like obesity, really change things like the gut microbiome. And the gut microbiome probably influences lots of systemic responses in terms of pro-regenerative effects. So we repair better when we have a healthy gut microbiome than we do when we have an abnormal one. And so I think the way that osteoarthritis research, certainly in the past few years, and this has been fueled by genetic studies rather than anything else, which we like to think are quite agnostic. You know, we've gone in with our own hypotheses for so many years, but now we can take a step back and go, well, what do the agnostic studies really tell us about disease? And those seem to be really pointing towards repair, that there's a failure of repair in those individuals who are more likely to get osteoarthritis. So maybe it's, you know, it's perfectly normal that we get this wear and tear of our joints. It's inevitable as we get older if we don't keep our muscles really strong, for instance. But our ability to activate a repair response is probably what marks out those people who are going to get that. And I think having systemic inflammation, having an unhealthy gut microbiome and so forth, those things probably just mean that your ability to repair those micro injuries is substantially reduced. That would be my hypothesis at the moment.
Yeah, it sounds like I've possibly been thinking about it a bit back about face in that way, in that I was sort of thinking about it as in the systemic inflammation was causing a worsening of the degradation, whereas actually maybe that's not quite the case. It's just not being able to be resolved quite so effectively.
I completely agree. And I think your view would be how the entire field was sitting, well, probably still sits actually, and probably it's just me that thinks differently about this. But if you look at genetics, the genetics are really showing us that growth factors are coming out, hypermorphic variants in TGF-beta family, FGF family. They're very strong in GWAS studies now. They're all sitting in these pathways, multiple different genes, all in the same pathways. And that tells us that's exactly why they did GWAS, right? Because that's what the geneticists told us, is that it's not individual genes that we're interested in. It's when clusters of genes start telling us the same thing, then we think, hang on a minute, this is telling us something really important about biology. And at the moment, bearing in mind there are lots of GWAS putative hits that we don't really understand what their function is, but the ones we do recognize are not in inflammatory pathways. They're not in this, what we call mechanoflammation. They're not in proteinases. They're not in any of these degradated molecules. They're all sitting on the other side. They're all sitting on the repair growth factor side. And interestingly, those are the same growth factors that we find sitting in that pericellular matrix in cartilage. So this, to my mind, this is aligning extremely well the big GWAS human studies with the sort of careful molecular studies, the mechanism in response to injury, and then, as I'm sure we'll come on to talking about, the ability of articular cartilage to repair itself after it's been injured, which up until now we've all assumed just didn't happen.
Yeah, brilliant. I just want to pick up slightly on you said about how if you're paralyzed or you don't load through your knee, for example, you won't develop osteoarthritis. Can we just talk slightly about sort of radiological or let's say pathophysiological osteoarthritis versus clinical sort of presentation of osteoarthritis? Because, you know, I suspect of our listeners, and certainly I have seen in the past, you might x-ray someone's knees, for example, and it turns out the painful knee looks completely normal, for want of a better turn of phrase, and the other knee, which is asymptomatic, is got sclerosis and thinned cartilage and all sorts. So are we talking clinical or radiological or combination of the two with this development? And would you also speak to a little bit about, you know, are there any factors that mean that are separate to what we just talked about, that someone's going to be more likely to get symptomatic osteoarthritis or more likely to have asymptomatic sort of degradation of that matrix?
Yeah, I mean, that's obviously another billion-dollar question in osteoarthritis research that's torn the field apart, because, again, it's one of these statements that you see in a lot of the textbooks. You know, there is discordance between structure and symptoms in osteoarthritis. Well, that's obviously too strong a term anyway, because there is some concordance, actually. It's just that it's not always as good as you'd expect it to be. So I think there are two things to say about this. The first is that without a doubt, one of the big developments, areas of interest that people have started working on in the past sort of 5 to 10 years has been this concept of pain thresholds, and some people having central sensitization of their pain, which is basically an abnormal amplification. Well, it might be normal, but it's an amplification of that pain syndrome. And some individuals appear to have that more so than others. And so when you say how painful is that knee, they'll put it as a 10, as opposed to another person might put the same pain, if you could measure it objectively, as a 4. And one of the ways that you can try and control for that is to, and this is a very beautiful study that Tahina Nioji published in the BMJ some years ago, in which she only looked at patients within a couple of their big cohorts, but she only looked at individuals who had unilateral knee osteoarthritis. And so in doing so, she could kind of control for pain according to the normal knee. And that meant that she was able to then make a more sort of easier assessment for how pain relates to function. And when she did that and only looked at these individuals with unilateral knee osteoarthritis, she actually found a really good correlation with the Kellgren and Lawrence score and with the chance of having a painful episode. And what was very interesting subsequently, she then said, well, okay, so the Kellgren and Lawrence score is a radiological score. It's both joint space narrowing, which is a feature of cartilage loss, and it's also resulting bone changes, so osteophytes and subchondral bone sclerosis. So what if I then separate the two bits of that score to see whether it's mainly the joint space narrowing or the osteophytes and the subchondral bone sclerosis? And when she did that, I think to her surprise and to my delight, she found that actually it was the articular cartilage loss, it was the joint space narrowing that maintained that relationship with pain. So there was a linear relationship with pain. So actually, I think some of these studies do show quite good concordance when you try to account for the fact that pain thresholds are so hugely variable between individuals, and therefore when you're looking at whole populations, it's extremely difficult to understand that complexity. The reason why that for us was interesting at the time is that we'd done some studies in preclinical models in mice showing that they get pain very, very late, which is sort of what we think of in patients, that actually you can have quite a lot going on an X-ray or an MRI before a patient actually has substantial symptoms. And it seems to occur exactly when the articular cartilage breakdown gets to a certain level in the joint. And that's when we see nerve growth factor being regulated, being made in the cartilage. So it's not being made in the other tissues of the joint, it's being made in that damaged cartilage. And so I do, I'm a bit of a purist, and I think that a principal driver of pain in osteoarthritis is the damage to the cartilage, the one tissue in the joint that doesn't have nerves. And again, if you go back to the textbooks, it's another line in the textbooks that say, of course, we know that pain can't arise from the articular cartilage because it doesn't have any nerves. But we know that the cartilage becomes neo-innervated. So you get new nerves forming, going up from the subchondral bone into the cartilage in late stage disease. And that's been demonstrated nicely in the past by David Walsh and people in human tissue, and by Anne-Marie Malfay and her team in mouse tissue as well. So I think we're sort of rewriting the textbooks at the moment, but I think there is a correlation between structural damage and pain, as there should be, really.
Okay, perfect, fine. And I think one of the, if we come to the shear forces, because I think that's one thing that I think as physiotherapists we're going to be particularly interested in, because let's say for the time being that, so you've got these shear forces which we're saying are causing a big part of the problem. Is that something that we can measure? Because if we can't measure it, then we've got a problem with regards to management, in that how do we know when we're giving exercises or activity programs that we are controlling the shear forces. And because if we're not, I'm going to make the assumption that we're actually going to make potentially the osteoarthritis worse. So I don't know if that's a question, but do you see where I'm sort of coming from?
Yeah, I absolutely. And I've been asking, the sort of gait biomechanics people and the engineers for years. Surely there must be a way of being able to assess, what that slippage is during mobilization, because it's all very well doing an anterior draw test on a patient to see what their ligaments are like, and that might give you some indication of what shear is going to be exerted on the joint while they're walking. But actually, you can compensate for a lot of that if you've got very good muscle support. So what you really want is something that's dynamic. And I'm told that there isn't anything that's very good at assessing that, but this isn't my area of expertise. So I don't know whether the physiotherapists are better at assessing it than anyone, and whether you can watch somebody as they walk and get a sense of whether that joint is moving more than you would want it to on its plateau, for instance, in the knee. The other thing that I think we haven't explored, which I would be very interested for someone to explore. It's not quite my area, but there's a lot of work that's being done by Phil Conahan in Leeds and by Mike Bowes and so forth in iMorphics. And what they have shown very beautifully is that if you follow up groups of individuals, either with just common and garden osteoarthritis, or if you take ones that have had an acute ACL or so forth, you get this very rapid bone remodeling underneath, and you get an expansion of that tibial plateau. And you get what he describes as a pie crust. So if you look at 3D reconstructions from the CT, you'll find that there's sort of ridges of extra bone that go onto the side. And you see exactly the same thing in mouse models as well. And that to me is a very mechano-adaptive response. And that to me suggests that the joint is doing this. And so the body responds by building up bone underneath the bit that the sort of, it's going to fall off the end, and so it has to build bone to try to contain it. So I wonder whether that mechanoadaptive response in the bone might be a helpful biomarker for those individuals who have got this functional instability. But that's very much a speculation at the moment. I don't think we are able to do it very easily. So I don't think there's anything a physio does. Well, this is a really stupid thing to say, isn't it? Because I have no idea. But I would say that nothing a physio does is going to be bad, because just building up the muscles is going to be good for the joint. And increasing exercise, increasing activity, I think is good. And there are clearly some things that you probably would not advise, like doing weightlifting and squats with hugely heavy weights if you haven't got strong quadriceps to start with. But generally speaking, anything that builds up those muscles is probably a good thing. It's a good place to start anyway. You're much more sophisticated than I am in this area.
Yeah, I suppose there's a balance potentially to be struck, isn't there, between let's say that let's make the assumption for a second that the shear forces are there and can be improved by the muscle tolerance, that the only way of doing that is exercising. So there's a period of time where you would have to accept maybe you were going to increase some of those shear forces in the short term to decrease them in the long term. And as you said, that sort of that appropriate loading, weight-bearing loading, is probably going to be beneficial as well anyway. I suppose one of the things that's toying on my mind to a degree is, do you think we should avoid things that would be more likely to cause a shear force? So I'm thinking, if we take the knee, something like if you were to do hip abduction, for example. So let's say you were standing with a weight on your ankle and you're abducting, because that would cause a valgus stress through the knee. Is that something we should look to avoid and go for more, I suppose, closed chain activity, so the foot is fixed so that, or do you think we're nowhere near that? Because I'm just hearing all the physiotherapists in my head going, well, how do we move forwards with this if the shear forces are a problem? Because we can't measure them, and the big problem I would have with the measurements anyway is, unless they're huge, we're going to have a big variation in what's normal as well. So how would we determine one person's normal versus someone else's? And is there again, like you said, the threshold is a little bit of shear okay, and is there a threshold where it falls over? So I think the measurement's going to be impossible. But I'm hearing all these physios in my head going, how do we know? And I don't know if you have an answer for that, but
well, I don't really, because I'm not, haven't been trained in your science and skill. So I don't know to what extent you can get effective muscle strengthening by doing, the same exercise that you're talking about, but with the foot still, firmly on the ground. If you say to me, well, it makes no odds, it doesn't matter. You don't need to. You don't need to adduct the hip with weights in order to get the same effect, and you can keep the foot on the ground, and it has the same effect. Then that might be fine, but I don't know, and I could speculate, but I kind of often sense that. I mean, I suppose it's a bit like, if you want to build up the quadriceps muscles, you don't sort of just get patients to do a step machine, do you? You'd combine that with some more, I don't know what you call them, static exercises, where you just get, you can flex and strengthen your quadriceps without actually having to sort of go up and down stairs. Yes, I'm talking well outside my comfort zone here.
I suppose this is sort of where I'm really like a high load static exercise.
Yes.
I'm wondering,
it's probably better than a dynamic exercise. Probably. That's what I would speculate. And I can tell you, if you like, how we came across this, because it was entirely serendipitous. We were asking a very, very simple question, which is that, okay, we'd made assumption, this is going back a few years, but we'd made an assumption that osteoarthritis was a molecularly driven disease, right? It was active. Then we made another assumption based on other people's work that this is driven by key proteases, so enzymes that degrade the matrix. And so we asked the question, in mice where you've just induced osteoarthritis by destabilizing the joint surgically, can we see those proteases being regulated in the joint? And then the other key question is, to what extent are those mechanosensitive? So if you immobilize the joint, do you still see those enzymes being induced? And so what we did for this experiment is we first did a whole series of a time course to say, are the enzymes being made? The answer is yes. Lots of inflammatory genes get made. So all the cytokines and the chemokines and the enzymes and so forth. They get made really, really early. So we could detect them within 4 hours of destabilizing the joint. And so that enabled us to do 2 experiments. We did an experiment where we destabilized the joint of the mouse, but we kept it asleep. So it never woke up from its anesthetic. So it was asleep for the whole 4-hour period. Or we woke it up and let it run around. And they tolerate this surgery extremely well. So they run around very quickly within about 15 minutes. So the mouse that had been running around on this destabilized joint for 3.5 hours had all of these inflammatory proteins and proteases go up. And the mouse that had been kept asleep for the whole time, even though it had had that surgery, nothing. All of those genes were down. So that told us immediately that all of that gene response was mechanosensitive. And so we thought, well, okay, that's very interesting, but can we show that this is more sustained? And so we did this and therefore protect the joint if you immobilize it. So we did this using a different type of immobilization of the joint. And we did this by cutting the sciatic nerve. And that means that the mice still walk around, but they walk around with a completely straight leg because they don't have the ability to bend the knee anymore. So it's completely rigid. So it's like it's splintered. And they run around and they seem to tolerate that quite well as well. And when we did that, we found that at 4 hours, the same time point previously, we didn't quite see all of the genes going down. And it was about half of them disappeared, like we'd seen before, and half of them stayed up. And it turned out that the half that stayed up, I'm sorry, this is a slightly complicated story, but the half that stayed up were all the growth factor driven ones. And remember, you've got this rigid joint, which is still taking compressive load, but it's not shearing because it's not bending at all. And so we concluded, and those mice then were protected from OA. They didn't get OA at 8 weeks and at 12 weeks following surgery. So we concluded that there are two distinct types of mechanical stress that turn on distinct groups of genes, as I mentioned before. And the compressive load is actually very good for the joint, and that's your growth factor driven pathway, and your shear stress ones, or at least ones that are induced on a destabilized joint when you are bending the knee joint, is driving the degradative pathways associated with disease. So that was by chance that we happened to sort of dissect these two by keeping the knee or the joint as static as possible, if you're still able to improve, if it's possible to gain that muscle strength in the same way.
Fascinating, amazing. And so, I mean, immediately my head goes to bracing at that point. And again, we fall into the same sort of problems in that, how do we know a brace would reduce these shear forces, because we can't measure the damn things at the moment. So I then go, okay, so if we want to, we'll make the assumption that we want to reduce the shear forces. Do you think, or do we have any evidence that and I know you've got distraction bracing, which we'll come on to in a minute, because I think that's a separate topic, isn't it? But anything that's going to stop, let's say, lateral movement of the knee joint bracing, in your mind or in the research, do you think that's an improvement because it reduces those shear forces in the short term? Or I would be concerned that actually that's going to compensate for the muscle function, so you're almost going to then just need bracing in the long term. So would you comment on that a little bit, if it's worth bracing for that reason?
I think that's a really important point you make, and we can brace in the mouse. So we made braces for the mouse, and we can get the same biological effect. So it dampens down all of the enzymes just in the same way that sciatic neurectomy did. So I always felt that probably if I had an acute ACL, I would probably, this is what I would hypothesize, that I would want to be braced for, I don't know, 2 weeks. 2 weeks is about the time it takes for the acute injury response in the mouse, at any rate, to settle down. So all those genes then sort of settle down to a grumbling state thereafter. And so possibly bracing initially might help protect that very vulnerable joint where there's a lot of other inflammation going in because you've just sustained an acute injury as well. Thereafter, of course, you've got that big problem of now you've got muscles that are weak and are deconditioned. And so what do you do then? You sort of get the patient walking again, and they're worse than they were right at the beginning because they've now got an even weaker joint. So I think it's a really, really difficult problem. But I think that does bring us on to the joint distraction, because those individuals are completely braced, by nature of having this surgical intervention, which completely an external fixator, which stops the joint from moving at all. And yet, when they get rehabilitated after 6 weeks of wearing this, they seem to do very well in the longer term. And so that suggests that you can compensate. And if you do the right physio afterwards, and you make sure that patients don't overdo it, but build up that activity slowly and carefully, then perhaps it doesn't matter if you have this period of immobilization.
Yeah, fascinating. Because I think when I heard you speaking on the other podcast with David, and it was the first time I'd heard about this idea of distracting the joint for a period of time, allow the cartilage, for want of a better term, to recover to a degree. And I think, if my memory serves, you were talking about as well sort of the distraction braces that weren't surgically attached, and that they were much less effective. And please correct me if I'm misremembering. And it does make me think that once the process has started, we really, as physios, we shouldn't really worry about the shear forces at that point, because it's already started, and we'll just work as we have been to improve things. And I think there are some conversations we can have as exactly how we do that. But yeah, it's fascinating. So would you mind just commenting on those distraction braces that you used and what then happened? Because there was quite a marked improvement, wasn't there, in cartilage?
Yeah, I mean, I should say that these are not primarily my studies at all. We've worked in collaboration with the Utrecht group, who really started this whole area. But before I talk about that, I think it's worth just saying something about these trials that have been done with external braces, not fixed braces, non-fixed braces. And generally speaking, they haven't been very successful. But I think that we come back to the same issue of, we don't know whether we're actually reducing those shear stresses effectively. That's going to be down to the quality of the brace and so forth. But also a really major problem is compliance. Because if you've got a brace that you can take off to have your bath or to sleep in and to do all these other things, and then, well, maybe you're just puddled down to the shops, before you put your brace on and so forth, then actually it's really difficult to then assess their efficacy in that context. So these joint distraction studies are really quite extraordinary. I think they've really turned the whole field on their head, because what they show is that if you fix the joint by putting pins, it's an external fixator like you would use for a complex fracture, pins on either side of the joint through the tibia and through the femur. And then instead of just leaving it fixed, you actually just distract it. So you pull the two joint surfaces apart by about 0.5 centimeter. And that 0.5 centimeter is an arbitrary level. It's meant to be, the tissue is still touching, or at least it does. You've still got a bit of give. You can still compress that joint, but most of that load is going across outside the joint rather than through it. So you're substantially reducing those compressive forces, but you are completely getting rid of those shear forces because you've only got compressive load for 6 weeks now going through the joint. So the studies have been done either for 6 weeks or for 3 months, but it looks as though 6 weeks is just as effective as 3 months. And what the group in Utrecht have shown very nicely now, and I think they've got 10-year follow-up for this initial cohort of 20 patients. There's no control group, but nonetheless, these are individuals who were in their 50s and 60s, so they were deemed to be too young for a joint replacement, and so this was offered to them as a sort of potential, sort of putting off, palliative, well, not palliative exactly, but a sort of trying to delay the time to joint replacement in these young individuals. So 20 patients, and they had very substantial improvement in pain and function after the 6 weeks, so after they'd been rehabilitated, and this really goes out, certainly 5-year data are published, and I think they have longer data as well. But what was more remarkable is when they looked by MRI on these individuals at 1 year and 2 years after they'd had the distraction, is that where they had bone-on-bone cartilage loss, they actually appeared to have regrown something that looked, at least by MRI, to be identical to the hyaline articular cartilage. And that was sustained for 2 years and 5 years and so forth. So we know that that's quite good quality tissue, whatever it is. So we did a study in collaboration with them in another group of 20 patients, because they're now doing this pretty much routinely in Utrecht, in which we took synovial fluid samples at the various different points at time 0 and then halfway through and then at 6 weeks when it was removed. And we showed that there was a huge change in the biology. And in particular, we found 2 growth factors that really correlated, their increase over time correlated with a good clinical response. This was just a small study, but nonetheless, it was proof of concept that this environment that you had generated by distracting the joint was actually pro-regenerative, that was really enhancing the ability of this articular cartilage to repair, even though it was bone-on-bone loss at the time. So this is the first evidence that we have that severe osteoarthritic cartilage is able to reverse itself and to repair itself. So I think that's enormously important. And again, that fits very well with the GWAS studies, suggesting that hypomorphic variants in growth factor genes also seem to be driving an enhanced risk of developing osteoarthritis. So I think we've been thinking about OA in perhaps a slightly different way for a number of years, and it's time to sort of switch it around and think about pro-regenerative therapies and have ambition to reverse some of this. So I know what your next question is going to be is, can physiotherapy do the same as joint distraction? And it should be able to, right? Because if you get that splinting, if it's just to do with reducing shear stress, and actually the compressive load is the bit that's actually good, that's the bit that's driving the growth factor responses, then reducing shear stress in the joint by physio should actually be able to improve patients and reverse their disease. And I think, if you look at the epidemiology, there's plenty of evidence that patients get better, even on an X-ray over time. So if you look at the big epi cohorts, 20% of patients will actually go down a KNL grade over time. Lots of them stay stable, and 30% or so will get worse over time. So I think it probably happens all the time. So I guess you're doing a great job.
I'm thinking that I'm certainly thinking that with the cartilage loss, I think that probably we'll find eventually at some point, you'll probably find this, is that physio helps probably earlier in the disease process, whereas then you get to the distraction later, because I suspect from what you're saying is that once you pass that threshold, you were saying about when you get to a certain degree of cartilage loss, loading is painful, isn't it? So I wonder whether at some point you just can't load appropriately to do physio to help yourself because you are pain limited. So that leads me to a slightly different new question, which would be, right at the beginning you said that joint injury is the biggest sort of predictor or precursor to going on to osteoarthritis. And I think we're fairly confident in saying that, and seeing that in meniscal tears and ACL injuries, we clearly see that, don't we? So I suppose I want to ask you about when people have those injuries and then they go to rehab, what kind of we're obviously going to be rehabbing them to ideally back to their previous function, but do you think there is also therefore a argument to be made to be continuing that rehab longer term, in that checking in with people, because we might not be able to measure shear forces, but we can certainly measure muscle strength, left versus right, function. There's a lot of research into like drop landings and how people's joints might react differently with regards to that information. So do you think we should keep ongoing monitoring to make sure people maintain their muscle strength in their injured leg so that they maybe don't succumb to these shear forces? Or do you think once they've sort of regained normal function that they're probably okay from that point of view? But I suppose if they're still predicting that they're going to go on to get osteoarthritis, they're probably not okay.
Well, you're probably aware from the studies that have been done in this area that about 50% of those that get an acute ACL or acute meniscal tear will go on to develop osteoarthritis, even though they're very young. So it's not a given that they all will, and we really don't understand yet which ones will go on to get this and which ones don't. And my colleague Fiona Watt, who I work with, is looking at that and has one such cohort, because it may be a combination of genetic factors on top of the injury. It may be things like the functional stability of the joint after the injury. What it doesn't seem to be related to is the whether you have a repair or not. So if you try and sew the ACL back, it doesn't seem to affect your longer term risk. And that may be just because you're not getting functional stability back, even if you're getting anatomical correction of the original injury. So yes, I think that you do need to give them advice. Your clinics will be absolutely stuffed full if you can never discharge any 20-year-old who's had an acute ACL. So, and I think you're also right to say that if you're young and you have got back to functional activity, then that will self-perpetuate, because you'll use the joint normally and you'll keep it strong and so forth. So that individual is probably a bit safer. But the principle still is the same, which is that you have to keep on making sure that those muscles and that joint stays as stable as possible, using all the means at your at your fingertips, which could be lifelong physiotherapy. I don't think your managers will thank me for saying that.
No, for sure. And there's part of me that's sort of thinking that there's a real educational component as well, in that if you have that sort of intra-articular injury, that some of those people will not get back to their previous level of activity, and therefore their other health measures will be lower, in that, you know, they might have a higher BMI, or just their general activity levels might be lower, which is going to be, as we talked about, is going to restrict their restorative processes as well. So it sounds like even in those younger patients, we should be giving them that education, in that we know that actually this is associated with you developing osteoarthritis earlier. So, you know, don't smoke, keep your weight under control, keep active as much as possible. Fascinating conversations there to be had, I think. And certainly in the physiotherapy world, there's a paper that was released this week or last week, I think it was this week as we record today, about treatment for osteoarthritis, physiotherapy for osteoarthritis, and they seem to have shown no difference between lower intensity exercise and higher intensity exercise. And, you know, as you said, that there seems to be some thresholds which might be individual, and that might answer that question. You know, if you happen to get all the people with a lower threshold in the high intensity group and the other way around, then that might be problematic. But I also wonder about whether we need to be taking a slightly different approach, and I'm really jumping the gun here, into different types of strengthening exercises, rather than, like you said, big movements like squats, or whether static strengthening might be a more appropriate thing to test. And it would be something to test the difference between static versus a dynamic exercise and see whether you've got any differences. So my head's sort of churning with regards to that.
I think you're absolutely right, and I think those things would be worth testing. I think the other problem, of course, we have in all osteoarthritis clinical studies is that our clinical outcome measures are pretty blunt. So putting aside the problem we have with central sensitization, you know, we've got blunt imaging biomarkers, we've got no molecular biomarkers that have utility, and we've got patient-reported outcomes which are very variable. So, you know, it may be that what you're testing has been successful, but actually your ability to demonstrate that in a clinical setting is very limited.
Yeah, fascinating. Yeah, lots to think about. So just as we sort of wrap up, I just wondered if you would comment on sort of what the next few years hold for osteoarthritis, especially with relevance to our audience, physios and therapists, but what's sort of on the horizon for your research, and what are you looking at?
So we've got lots of really exciting things going on at the moment, and they're all slightly disparate. I mean, they've all come from slightly different angles, but they all have mechanical load, mechanical shear, mechanical injury as a sort of central theme. So, for instance, I think there's a huge amount we should be learning from genetic studies, because I think we are able to then, if we can align molecular pathways that have been identified on genetic studies with those that we're doing in vitro and in vivo, and everything sort of matches up, then I think we've actually got a really good basis for saying this is something that's worth now putting into a patient. The other thing that we're starting to do quite a lot of, which I think is absolutely the sort of halfway house, because you can't go straight to a clinical trial. No industry partner is much interested in osteoarthritis, if the truth be told. And those that are, you know, they're terrified of it, because these are so expensive, these clinical studies. And so what we have to do as academics is do the middle piece, which is what we call experimental medicine. So it's doing studies in patients with disease, but in very small numbers, and looking at perhaps a molecular outcome measure rather than a pain score or a function score, because you need far fewer numbers in order to get your signal to give you some validity that that pathway is worth testing in a bigger sort of clinical study. And so we're doing that. We've got a couple of experimental medicine studies. We're doing one looking at retinoic acid, because retinoic acid is one of the GWAS hits that happens to be highly mechanosensitive in the joint as well. So that's very interesting, and that's already started. We're doing some other stuff, looking at novel targets in patient groups for the first time. So I think that's where it will go. I think after 20 years of having worked in osteoarthritis research, and I should give a call out to Versus Arthritis, who have funded our Centre for Osteoarthritis Pathogenesis for about 8 years now, and took a decision about 10, 12 years ago that actually osteoarthritis was one of the really big unmet needs and required a lot of investment in terms of funding. And I think much has come out of that initial investment. So through our centre, we'll continue to do that sort of molecular interrogation of the pathways, but really shifting this into that middle ground for the first time, which is to actually look at novel targets, novel validation in patient groups. Because if you don't do that, you can spend all your time in the preclinical mouse world, and you can spend all your time doing clinical trials that industry have dreamt up. But actually, if you never move those novel targets into patients, industry just won't do it. We have to do that within academia. So that's where we're going to sit, I think, for the next 5 to 10 years.
Amazing.
If I continue to get funding.
It's all absolutely fascinating what you guys do. My sort of just final question, really, there's been a lot of talk on social media in probably the last 12 months about steroid injections for various reasons. But I just wanted you, whether we can do this as a yes, no answer, but steroid injections for osteoarthritis, good, bad, the worst thing, the best thing, thoughts?
Well, do you know what my thought is about this? And I'm afraid this is complete speculation on my part. So you know that the controversy at the moment is that we give these injections, patients feel a bit better for 3 months. If you look at the placebo-controlled studies, there's a huge placebo effect. There is a therapeutic response, but it's pretty modest. And it's often in select outcome measures rather than, single primary endpoint measures. So the studies, I think, don't really show a huge benefit. But the concern, of course, is that repeated intra-articular steroid over time, like the study that was done by Tim McAlinden, show that actually there isn't very much of a clinical response, not at least at the 3-month time point. And moreover, at 2 years, there's actually slight worsening of the cartilage degradation in the patients who were receiving repeated intra-articular dose every 3 months. And, I'm not altogether surprised by that. I often think of the synovitis as being just a reaction. It's like a really rapid response in your body saying, hey guys, there's inflammation, there's damage going on in my joint. That inflammation in the synovium might be good. There are lots of people in the field trying to reduce it all the time, but it might be good. Or at the very least, it might be an early warning signal. So it might be there to say, you've got a damaged joint, don't overdo it. And by reducing it, by suppressing the inflammation, by suppressing pain with steroid, it's a bit like giving analgesia. You're just hiding the fact that your body is trying to repair itself, and it's telling you that you need to sort of rest that joint for a bit. So that's a really boring answer, but it doesn't surprise me, because I see absolutely no evidence at all from the preclinical work. And I'm sorry, everybody knows that I bore tirelessly about this, that inflammation is a good target in osteoarthritis. All the clinical trials that have looked at anti-IL-1, anti-TNF, anti-IL-6, hydroxychloroquine, they have all failed. And there are still people who say, oh, that's because the clinical trial wasn't designed correctly, or we didn't look at this, or we didn't stratify patients. But, you've got to take things at face value, and there's no biology to support that. There's just a lot of in vitro circumstantial evidence that IL-1 is great at degrading cartilage. We know that, but that doesn't mean to say it's driving it in osteoarthritis. So I still give steroid injections, because in the absence of having anything else to give to patients, they do value it, and they will get a very good placebo response, and they will get a little bit of something else. But I think I'd be cautious about giving too many of them to the same joint.
Perfect. Brilliant. So finally, where can we find out more about you and keep on top of your work and publications?
So we have a website for our OA Centre, which is in the Kennedy Institute page. And I can forward you the link to that, because I don't know it off the top of my head. I should do, shouldn't I? And so you can follow what we're doing there. And there are various contact addresses and so forth if people want to get in touch.
Brilliant. Absolutely brilliant. I'm so happy that you spent some time with me this morning doing these recordings and answering my questions. And certainly I've got so much to think about. And I think the physiotherapy world has a lot to think about with as to why some of these trials more recently with our interventions are not coming out with the positive results necessarily that we thought they might do. And I think some of the work that you're doing might provide us with some answers, or at least some new things to test maybe, as to how we apply the strengthening programs, or how we apply exercise programs, or why when we test them, like you said, with specific outcome measures, maybe we're not seeing the outcomes we thought we might do. So yeah, absolutely fascinating. So thank you very much.
Pleasure.
No worries.
Thanks for having me.
No, well, definitely would have you back again and talk a bit more.
Give me another 20 years and I might have discovered something else.
Right. So there we are. I hope you enjoyed that. I am going to be certainly listening back to my own recording multiple times to make sure I understand everything that's gone on in there and how I'm going to apply all of that to clinical practice. Like I said at the beginning, I'm certain that this is going to generate a lot of conversation in the rehab world. So please do get in touch. Let's crack on with that conversation. We're on Facebook, Instagram, Twitter. You can find us there or email us info@physio-matters.com. Don't forget as well to make sure you take advantage of that amazing deal with Active Force. Just to remind you of the URL that you need to go to, physio-matters.com/AF and then the number 2. So that's AF2, and you'll be able to find all the details there. And it really is an excellent device and just a ridiculously good price. So do go and check that out. Don't forget to subscribe to the show. If you're listening on a podcast app that allows ratings, then please do give us a rating. It helps us get up the search functions when people are looking for our podcast. You can always comment as well, and we always love to hear your feedback. So hopefully we'll be hearing from you all soon. And it's my job this month to do the cheesy sign out. You've been listening to the Physio Matters podcast, discussing physio matters because physio matters. Bye for now.